Good evening, everybody. I'd like to welcome you to our webinar tonight on real-time release of complex labs to your patients and what this means to your practice. A couple of housekeeping notes. Your mics may be on and your cameras may be on. If you don't want them on, please mute yourself, turn your cameras off. We have a number of presenters tonight. We have Dr. Brad Baylor from Primary Care, Dr. Dave Sidhu from Lab Medicine, Dr. Julie Lazon from Clinical Genetics, Dr. Oksana Sukowirsky from Neurology and Clinical Genetics, and myself, Dr. Heidi Fell, and Dr. Steve Turner, who is from AHS, as the moderators today. This is a live recording, so please note that it's being recorded, will be posted on the AMA website and potentially the AHS website for an undetermined length of time. And by participating in the chat and live Q&A, your name entered in the Zoom sign-in might be visible during the webinar and or in the recording. Next, please. We'd like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, 7, and 8 territory and is a traditional and current meeting ground and home for many Indigenous people. We also grieve the loss of so many Indigenous children along with our Indigenous friends, colleagues, and communities, and reflect on our commitment to the principles of truth and reconciliation. Our Indigenous Health Committee at the AMA is leading us in our work to implement the AMA's policy statement on Indigenous health, which sets out our association's support and commitment to respond to the Truth and Reconciliation Commission of Canada calls to action on health matters. The policy statement also reflects our determination to provide leadership in improving access and quality of care for Indigenous communities in Alberta. As this is a CME accredited event, we have some disclosure slides, and this program has not received any financial or in-kind support. For presenter disclosures, they're as presented on the slides. Other than employment relationships, only Dr. Sukowirsky has any conflicts, and they are listed there. So for our overview today, we're going to talk about the planned release of microbiology, pathology, and genetics results into the MyHealth Records portal. This change is scheduled for August of 2021 now. We'll also talk a little bit about the variable portals that are available in the province to patients. And we've got presenters from a variety of specialties who will share their experiences and insights on what this change means to you for your practice and how to adapt. So our learning objectives here are to assess the impact of the real-time lab release onto your practice and the need for pre-test counseling potentially, and to evaluate the impact of this on your workflow, your clinic workflow, or your hospital workflow. At this point, I'll hand it over to Dr. Steve Turner.
Good evening, Heidi. Good evening, everyone. So what we want to do is just give a bit of background to describe what exactly we're speaking of when we're talking about patient portals. In the province, there are several types of patient portals, but we'll be focusing today on and particularly on the result release associated with My Personal Records, which is a portion of the Alberta Health's MyHealth Records portal. Additionally, there is another portal shared broadly in the province that supports Alberta Health Services patient care. It's identified as My AHS Connect, and for convenience for this presentation, you'll note the color change on the color differences on the slides. It's the information that's specific to the My Personal Records, or MPR, in light blue, and the green will represent those that are specific to My AHS Connect, if there are differences between the two portals and their functions. It's also important to know that COVID-19, there is a child lookup that's present within MyHealth Records that is separate from these two particular portals. We won't be focusing this evening on local portals that physicians may have related to their own electronic medical records. How they share information with their patients is really for their determination, and they support that those decisions locally within their own clinics. Next slide. So my personal records portal and the MyHS Connect portal are both accessed through Alberta Health's portal called MyHealth Records. In order to gain access to MyHealth Records, you need to be an Albertan over the age of 14 years of age and possess one form of Alberta identity, either through the Alberta identity card or a driver's license, and then complete the registration process needed to verify your identity and receive a Alberta Digital Identity, or MADI. Once that process is undertaken, you have the patient or Albertan has access to MyHealth Records for approximately 30 days until they receive a PIN. And once that PIN is used, that confirms their identity, and they then have ongoing and enduring access that needs to be re-verified on an annual basis. On this slide is a screenshot of the landing page for MyHealth Records, and you'll note there are two tiles there, one for my personal records and a second for my AHS Connect. One thing to call out is that my AHS Connect, that particular tile is only visible if the patient has been granted access to my AHS Connect portal. An Albertan who has not had access to or has not had contact with AHS at a site where Connect Care is being used would not have necessarily been given access to my AHS Connect. They would not see this tile, and they just see the My Personal Records, and it's in that space that their their lab results and other information is present. Next slide. So what we know already. So as of we've already identified who is able to see this information. So all Albertans who have access to MyHealth Records can see their lab information through My Personal Records if they're over the age of 14 and have completed the ID identification. As of February, approximately 95% of all labs created within the province, based on the 95% of the most common results, were present as of February 1st, and includes also information on COVID testing, and also immunization records are present within MHR and MPR. For patients of AHS, they are actually able to see they're 14 years of age and up, as can have direct access, and they also have the ability to review results and have had the ability to review the majority of lab results for the duration that the portal has been available over the last 18 months. So what is coming, what is happening is Alberta Health is moving to add the remaining 5% of lab results to the My Personal Records portal, and particularly the more complex results associated with pathology and genetics. Microbiology results were added to the release in the middle of June, and those results do not contain susceptibilities. The specifics around the genetics and pathology results will be part of the presentation later on, and so I will leave it to the experts. Next slide. And just for a bit of clarity, just as a reference, this slide identifies the two specific portals that patients may be seeing within MyHealth Records. There are some differences between them. Within My Personal Records, the patient can view their results, but they're not provided notification when new results are present in their portal. The patients who are part of the MyHS Connect portal, they do receive notifications when new results are present, and so may see their results very soon after they're released into the portal. We talked already about all of the lab results and the result release in real time. For prescribers or physicians working within AHS, you may be aware that there was a delay in certain lab types within within MyHealth Connect, particularly the pathology results and genetics results that we're going to speak about tonight, and diagnostic imaging results, and they were delayed approximately 5 days. With the real-time release now occurring within my personal records, that delay in release within MyHealth Connect will be removed, and those results will be released in real time as well. The exception will be the DI results, which will remain on that 5-day delay, as there are no DI results present within my personal records. Importantly, new users who join MyHealth Records will see an 18-month retroactive view of their lab data. For MyHealth Connect patients, or patients using MyHealth Connect, that retroactive view extends back to 2017. For my personal records, BrightSquid integration is available to support secure messaging should physicians wish to use that tool to support messaging with their patients. For physicians working within AHS, they have and on Connect Care, they have some additional connection or communication tools that they can use to support their patients through MyHealth Connect. And my personal records, there is no sharing by proxy of the information within that record, only under patient control. There is some ability for proxy access from MyHealth Connect following specific guidelines set out by Alberta Health Services. Next slide. So I'll pass the baton to Brad.
Thanks, Steve. So we're just going to go over some overarching concepts and some of the perspective from primary care. One thing about the release in MPR is that patients can see results as soon as they're available in real time. And depending on how you receive results as a provider, that may mean your patients see the results before you do. Most providers receive results in a batch feed, either through paper or through fax or electronically. And so that means providers would have access to the lab data in Netcare in real time, but may not have it copied in their local EMR or in their local clinic. There's pretty strong patient feedback. Real-time release is desirable. Even when it's bad news, patients do want to know. And the literature shows that having results released to patients reduces anxiety overall with real-time release. These changes are approved and overseen by the Health Information Executive Committee, which is the highest committee in health informatics in our province. And you can see the various organizations that are represented on the Health Information Executive Committee listed there. Let's go to the next slide. Some other considerations to think about is patients may contact the provider who did not order the test and may not have even been copied on the test. So in an instance where a specialty provider may have ordered a test, patients may reach out to the primary care provider as an example to discuss the result. And this requires, as a clinic and as providers, us to think very carefully on how we're going to handle those types of situations. So we may need to ask, what do I do if the result is critical? Because if a patient is reaching out to you with a critical result and you need help, it may not simply be enough to hand them off or tell them to contact the ordering provider. You need to assist them in achieving resolution with that critical situation. There may be results requiring detailed specialist follow-up, and in some results you may actually not know what to do with. There's a lot of context in terms of test ordering, and to be able to interpret the results of a test, you really need to be clear on what the question was that the ordering provider was trying to answer. And so I think the best way to frame this, if you're thinking through your clinic processes, is, be open and transparent with your patients. Be honest if you don't know what a result means, but be helpful in trying to assist them in connecting with someone who can help them. and get follow-up plans in place. We also know there'll be situations, and some may be appropriate and some inappropriate, where a provider may order a test in another provider's name. And there are legitimate reasons why that may occur, depending on coverages and follow-up situations in a province. And there may be times when this is inappropriate as well. And again, it's important to think through, what would you do as a provider or as a clinic in those situations? Next slide. So, in general, the number of inquiries from patients is typically less than we would expect. There are definitely a small number of patients that need coaching around communication on results review. And so this is an opportunity to have a discussion with your patients on how you will review results, what are the best channels to communicate around results, what are the limitations of testing and results and potential outcomes. And for some providers that do use messaging, asynchronous messaging, we need to be clear on how we'll use that system as it pertains to results, specifically that it's not really for urgent follow-up or urgent issues. And if patients have an urgent concern, they need to call or come in to see their provider rather than messaging and making an assumption that that's going to get looked at in a urgent fashion. Pre-test counseling is really a very important factor that I think sometimes in primary care we do well, and other times maybe we don't do enough. And it really does help in setting up patients around reviewing their results when they have access to them in real time, and sets expectations for patients around the review of those results. So, being clear on why you're ordering a test, what you're expecting to see in terms of a result, what does it mean if it's positive or negative, what happens if the result is unexpected, what are situations where there actually will be further testing required based on the result that you've gotten back, helping manage expectations around next steps regarding results. So, how is it that you're going to reach out to them? How is it that they should reach out to you if they have questions about results? Potential implications for family members, stuff like genetic testing, which we will get into in the next section. And also just be aware patients have link to access test information on myhealth.alberta.ca. So they can actually click a link that will take them to some information about the test, which may be helpful in some situations, but could potentially cause confusion in other situations. So it's just important to know that they have access to that. So in the end, having a really good plan with your patients on how you or your clinic review and act on results, and how you wish patients to act on questions they have, is critical. And patients do appreciate seeing results and having the ability to discuss them. There's a lot of good feedback, having the ability to review and discuss results, and not always have to do that through an in-person appointment. So things like messaging can be effective for this, or even phone visits can be effective for reviewing results. And there's great patient feedback where that's occurring in Alberta already. Many primary care practices actually have a fair bit of experience with using portals, and patients having access to results through those portals. So as an example, in my community, my practice has been actively posting all lab and DI reports for about 5 years. Again, the net balance of calls is fairly equal. Some patients actually call less because they're quite reassured being able to see the results, and some do call more, but we have a plan in place on how we deal with those call-ins. I will say that I think it's made the patients savvier and enabled patient self-management to a greater extent. It's actually been a very positive thing, having patients engaged in what the results mean and having them more involved in their own decision making. So that's been quite positive. We do use asynchronous messaging to review results, which has been extremely positive in our practice. And the pre-test counseling and planning is really key. Just going back to the fact I can't emphasize that planning and counseling is critically important. But there are new team processes that you'll have to consider. And so having scripting for your team members who might be taking those calls, having a really solid, reliable process for patients calling in to review results or messaging to review results is critical. And with that, I'm going to pass it on to Julie to talk about genetics.
All right, thank you very much. I did want to thank the AMA for organizing this webinar, and I've been asked to speak to some of the specific issues that we want to think through when we're talking about genetic and genomic testing. So first, I just wanted to identify what type of genetic testing that we're going to be talking about. In my practice, I usually do the genetic testing that's involved with the labs that we have through APL. So those are the ones listed here: the cytogenetics laboratory, molecular genetics laboratory, as well as biochemical genetics laboratory. I do recognize, however, that there are other labs that do genetic testing, such as a pathology molecular lab as well. So, and they will also, I think in the next session, this will be addressed. So what we want to think about is what types of testing that we do. So if you think of the cytogenetics lab, that's when we're talking about chromosome testing, so karyotypes or chromosome microarray. In molecular genetic laboratory, these is where you're doing the gene sequencing. And now we've moved on and introduced next generation sequencing, where we do things like gene panels, where we can integrate or interrogate multiple genes all at once. And then our biochemical genetics lab really focuses on inborns of metabolism, and that would include the newborn screening results that would also appear. And that, I think that's a little bit tricky because you have to be 14 to order to have an account. So I guess someone by proxy would be able to order it on behalf of their child, and they wouldn't reappear. So those might be a little bit tricky for families to find. But I will say that our metabolics team are quite quick at responding to these screening tests, and we have a fantastic program there that are quite expeditious in dealing with those results. The other piece is that currently we do know that there are tests that anyone can order, but there are some that are restricted, and having this patient portal will not change any of that. So some of them are, some of the gene panels are quite restricted. Some of the neurogenetic testing is restricted as well, and that will not change moving forward. Next slide. So I just wanted to highlight again a lot of the issues that you have to think about, but what Brad spoke about was the pretest counseling. And some of the important things that you think about in the context of genetic testing is we do spend quite a bit of time talking about the different types of outcomes in terms of what exactly does a genetic test mean. So we kind of characterize them very broadly as, is this a positive test? So for that is that we have found a genetic variant. And seeing a genetic variant, sometimes that is a positive test, but the interpretation of what that genetic variant means might be a little bit complex. It's pretty easy if you have a clinical diagnosis and you're just confirming your thoughts on what this could be. If you have a child in front of you with cystic fibrosis that presents with symptoms of cystic fibrosis, if you have two genetic variants that fit with that, then I think that would be a classic positive test. But sometimes a positive test might mean that a genetic variant is found, but we're not actually sure that that means that that person has that genetic test, because there could be some variability in their presentation. So there needs to be some pre-test counseling and some more counseling done about what that positive test actually means. Then obviously a negative test means that we haven't found a genetic variant. And interpreting that will depend on the type of genetic test that you ordered. Was it a very targeted test to try and confirm it where there's not a lot of genes that I could account for that presentation? Or did you do a very small search space in the genes that you were looking at, but you haven't looked at every gene that can cause that particular symptom or that particular presentation? Probably we spend most of the time as a geneticist talking about variants of unknown clinical significance. And this is a test that we actually don't know where the result means, is this a causative variant or is it not? So we do lots of work trying to understand what the variant might mean, but sometimes at the end of the day, we just cannot classify it as being causative or not. And we just need time to try and sort that out. Incidental findings are also common, but again, this will depend on the breadth of the testing that you're doing. If it's a broad test like a chromosome microarray, or if you're just looking at a very small subset of genes, but an incidental finding could be anything from non-paternity. It could be you're uncovering a genetic risk for a completely different condition that might present itself in the future, or something that you haven't recognized that might be present in the patient or in the family. And there's carrier testing that can be revealed as well as part of an incidental finding. Obviously, turnaround time is important. As most of you know, genetic testing takes a lot of time. So to prepare them so they're not always going into their portal to know that it'll take, in some cases, it could come back in a few days. In some cases, we're talking months. And as was mentioned before, the clinical implications, not just for the patient, but for the family members as well. And there could be a lot of effects, social and psychological impact. And I don't think it's very different from any of the other tests that we've been talking about previously. But setting them up and understanding if you're confirming a clinical diagnosis versus you're going on a bit of a fishing expedition, that might have different impacts. And we think a lot about social impact if we think of it in a context of a family history, or where someone thought that they were living with this condition, they were going to get the condition because everyone else in their family had it. But if they don't have it, that could also have an impact that we like to explore in the pre-test counseling as well. So I just want to highlight that a negative test, genetic test, does not mean it is not a genetic disorder. As I mentioned before, maybe your search space of gene has been small and you haven't targeted every gene possible. Or maybe we just don't actually know what all the genes are that cause that particular condition. And I can't highlight enough that a variant, if it's classified as a variant, it will be a variant. And budging that anywhere else can be quite difficult. We do family member segregation testing. We might want to do further what we call phenotyping of a variant. Can we find any clues that make this particular variant more likely to explain what we're seeing? But if you see a VUS, you cannot conclude that that is the cause. And explaining that to a patient could be really challenging. But that's something very important to highlight, and we're happy to help families who are struggling with this as well. So next slide. So the other thing to highlight is that even though we do a vast amount of genetic testing within the province, I will say that a lot of the more complex testing is actually not done in the province. So we do send a lot of our testing out to the US internationally. And so if they're not performed by our genetics and genomics laboratory or in our molecular pathology, they will not be released. So sometimes that's the reason why they won't see it. So it'll be important to give our patients a heads up that if this is going out to the US or any other place, that they were not going to find it in the portal. The other thing is that there are some exceptions for some of the predictive testing that will not appear as well. Next slide. So a little bit more about predictive testing. So these are people who do not have any symptoms, and they're coming to attention because of a family history mostly. In these circumstances, we do what we call is predictive testing. So they have no clinical signs, no symptoms of a disease, but they're interested in knowing if they carry a predisposition, if this will be part of their future potentially one day. So classic things that we'll offer testing for would be things like cardiac conditions, whether it's a long QT, a cardiomyopathy. We offer lots of cancer predisposition testing, BRCA1, BRCA2 being the ones that we mostly think of, but there's many others as well, but also neurological conditions. And I think the biggest difference will be whether it's released or not. All of the ones that I've just talked about will be released if they are actionable, meaning that there is something that we could do with the result to try and mitigate the effects of having any impact of that genetic variant in the future. Those that are not actionable, those that often fall in the context of a neurogenetic condition currently, will not be released. And perhaps I'll leave it to Dr. Sigorsky to see if she has any more comments about that, because that would be part of her specialty. So I don't know if Dr. Sigorsky has a few other words to add to that, or we can leave it to the Q&A.
Sorry. Yes, thank you, Julie. Just to again reiterate that predictive testing is always done in a confidential manner, and so we only release the information to the patient directly, and we send them a copy of the results. It's not on Connect Care, it's not on Netcare, and we feel that it is the patient's responsibility to tell who they want to tell, so we do not send letters back to referring physicians either. That's just sort of standard of practice in North America and in many parts of Europe, based on our previous history with Huntington's disease.
Thanks. So our last slide, I just put up here a couple of contacts to two genetic clinics. There's one in Calgary and the one in Edmonton. In Calgary, we have two separate clinics, the general genetics and our prenatal genetics. Soon to come will be our adult clinic that'll be at Richmond Road. So we'll get contacts to that out and about as soon as we're established there, hopefully in the next few months. And Edmonton's contact is there as well. I've also added the website where you could contact and get the information for all the genetics and genomic laboratory services within APL. And you'll see that they're listed as the different types of subcategories of labs that you could contact if you have a question with any of those tests that you're ordering. And I will leave it at that. I know it's a bit of a whirlwind tour, but I'll pass it on to Dr. Sadhu to talk about his perspective from lab medicine.
Thank you, Julie. So I want to echo what Julie was saying. We are developing an FAQ for our lab physicians as well. There are a few additional things that won't be shared, preliminary results, autopsy results. The list is being finalized, but it's important for the lab physicians listening to be aware that the reports will be released in real time. And also for the clinicians as well to be aware that, once they're available, patients may see it long before you would. There are all sorts of peculiarities with pathology reports in particular. The biggest one has everything to do with the amount of time a lot of histochemistry, immunochemistry, and other adjuvant testing takes. From a survey of other jurisdictions that have introduced patient portals and the lab experience in those patient portals, there's been two major questions from patients that may not be the questions that pathologists or clinicians expect to hear. The most common is, "This is not my test," and often it's because either the wording that's used, or they may have forgotten or don't know what additional testing was ordered. And so we're putting systems in place to field those calls before perhaps the patients even contact the pathologist directly. The other one, which is probably a reasonable question, it often has nothing to do with the diagnosis or trying to work through some of the complex jargon and other things in the report, but has everything to do with, why did this take 2 weeks? And so both clinicians and laboratorians should be prepared to manage patients' expectations, either prior to the biopsy or other testing, or when they are contacted. The concern from the patient's perspective may have nothing to do with the diagnosis and everything to do with the timing of those results and the anxiety that has built over the time. So Alberta Precision Laboratories is developing a guide for the lab physicians as well. There's a certain amount of apprehension for some of the pathologists who don't routinely talk to patients. It is important to note, based on the CPSA requirements and as part of the care team, that you cannot refuse to talk to patients. You may want to talk to patients in the presence of their clinician as well, and so you can answer questions related to the report, but not necessarily questions related to management and other things. And it's important to stay within those lines of what you're able to talk about. The other big concern from pathology and maybe from the clinicians as well has been identification of folks calling, and making sure you're talking to the person who is the patient or who says they are the patient. And we're going to include certain questions and other things you can do in those circumstances to establish the identification of these patients as well. Next slide, please. This is just a sampling of some of the the issues from the patient perspective as well, as far as their hope in being able to contact pathologists directly, and being able to understand their reports as well. The vast majority of folks really feel like this might help them, and they all want to know more about their diagnosis. And so from a patient perspective, any support, any information, feedback, consultation that they can get is always valuable. And we suspect most of these are, all of these are, the vast majority of them are going to be positive interactions. And that is the hope based on all of the other jurisdictions who've introduced this type of testing. That's everything I have.
Well, thank you for everybody. At this point, we're open to any questions. Dr. Turner and myself will help moderate those. We do have one to start off with, Dave, and that is, as a lab medicine physician, where do you document that you talked to the patient?
So that is a question as far as what we can do. As Connect Care rolls out, we'll have certain places that we can note the documentation. As of now, clinical care notes or some form of clinical note for the patient's chart, if they're an inpatient, may be an option as well. Realistically, Heidi, the details haven't been worked out. We've been reassured. Dr. Naherniak is working on a some form of notation in Epic. If you have SCM access, and many pathologists do, because a lot of the clinical history is very important to patient diagnoses, you can always drop a note into SCM as well.
Yeah, maybe if I could comment on that. It's Oksana. It is actually quite easy to leave a note on, in Connect Care under documentation, and then there's even a billing for MD to patient communication, so you can do the note and documentation and bill it, right? It's actually very efficient in Connect Care.
Thanks. We have an addendum to that question, which is, could you put an addendum on your report that you discussed it with the patient?
That might be possible. I'm not sure how modifiable the original pathology reports are. Maybe someone else has that information.
Yeah, I would say it's much easier to do documentation. There's a special little tab for documentation, and you just click it and write a little note. And that's probably better than addending a report.
Okay, Brad from primary care, where do you document your phone calls with patients or your messages with patients?
Yeah, I mean, in our portal, messages become part of the patient record automatically. Phone calls are typically added as essentially a visit type, and then documentation occurs in that. So it's all within our medical record.
And just to follow up, that if a lab report was addended with, has an, is that a word? If a lab report had an addendum attached to it, that would then be sent into the portal and the patient would be able to see it as well. So that's an interesting question. Tessa is pointing out that most family docs don't have the ability to see those Connect Care notes. And so, you know, that's an interesting twist to it as well. Dave, as you guys are figuring that out, is that, you know, how, if the family doctor is the one that ordered the biopsy or the specialist is the one that orders the biopsy and they work outside of the Connect Care environment, how are you going to communicate with them that the patient has had this contact with you? Dave, any thoughts on that?
Yeah, so we will actually, I'm looking at the FAQ just because I wanted to double check to see if we'd anticipated that. So the addendum option is actually there. So potentially that's one way to create a stopgap and inform the community physician. So they'll get another report saying that a conversation has occurred, and that might also be an option.
Okay, any other questions tonight? Steve, do you want to pick one?
I'm just looking at the chats. Sorry, not seeing.
I did see a question about what to do if you're away or not available, and so we have added that as a potential issue as well. So right now, it would be reasonable if you have anyone covering, or the clinical section chief or site chief that may be able to cover and have that discussion in your absence. Is the recommendation we're including in the FAQ. One of the other things we're exploring with APL is the creation of a potential on-call service as well, and that might be one way to deal with it. But the reality is the best option is for the diagnosing pathologist to talk to the patient directly whenever possible.
Steve, I think we have a hand up. Andrea, did you have a question?
I had a question regarding the instant messaging that's available. As a laboratory physician, I don't have any previous relationship with the patients whose reports that I'm signing out. Is there going to be an expectation potentially from the patients that they can message me and I would be monitoring that?
Steve, I think maybe we'll get you to answer that.
Yeah, so Andrea, it depends a couple of things, I guess. So within my personal records, so within the MyHealth Records reporting that we're speaking to primarily this evening, there isn't a messaging functionality there unless you've established it using Bright Squid or have some other way that you've established to have contact with the patient. From the perspective of the MyHS Connect app and the fact that identified that they can have patients can have contact with the reporting with their care team. It is in that instance limited to just those patients who are, or to those physicians who are part of their team, their care team, identified care team. And so they don't really have the ability to broadly message providers within the organization. So they wouldn't be directing queries to pathologists. You wouldn't be on their care team necessarily.
So Steve, they can add themselves to the care team if there's a requirement to do so, correct?
They can do that, and then they would then be visible to the patient for messaging. In that event, the way the process is set up, the actual questions would deliver to a medical question pool that's basically a triage pool that's managed by someone within your clinic or department, and manage some of the initial kinds of questions that can be addressed without direct contact to the physician or the pathologist. And then those that require that clinical input or specialist input, would be redirected from that pool to the physician.
We also have a question. If the studies that showed overall lower anxiety for patients, did they show any rate for adverse events? And so that's, so I don't know, Brad, do you want to take a shot at that one, or else I can add a little comment about that?
Yeah, I mean, I think anytime you quote a study or you look at literature, just because the rate of anxiety is overall lower doesn't mean some people's anxiety is not higher and then some are lower. So I think there are some adverse events in terms of just patient concern or worry, I would say, about lab results that do need to be addressed. It's just that overall there's more in the positive side of the equation than the negative side of the equation. And so, as a provider, it's good, again, just to have really good practices and protocols in place. So, if there is a patient who has anxiety or concern, you're able to address that as soon as you can.
I would just add that I don't think there's a rate mentioned in any of the studies because they're so rare as to not be measurable as a rate. So So, we all worry about the patient that gets extremely anxious and heads off and does something drastic, or, drives somewhere in a state that they shouldn't be driving in and gets into a car accident, for example. Those aren't reported frequently, for sure, in the literature.
So there's a question from Kelly.
I'm just wondering, I'm aware with some of my general pathology colleagues, when they've been on call and a INR comes through of 8 or 9, that they in turn discuss this with, or try to discuss this with the ordering physician, can't get a hold of them. And they have had to contact the police, who have gone to the patient's door and pulled them into the hospital. I get that this is potentially unlikely, but what if, if I'm doing a derm path service, I might be, reporting 300 surge path cases in a week. It's very likely that the patient will get their results prior to the physician having an opportunity, their primary physician having an opportunity to discuss something with them. Medical legally, is it appropriate for me to be talking with this person prior to having a conversation about their results if they call me up? Because right now my telephone number is on every single report I release into the system. What's the advice from CMPA around that?
So
great question, Kelly. Dave, do you want to go first? I have also discussed this with CMPA too. So
yeah, no, I won't address the CMPA piece of it, but I will mention that Kelly, you're not wrong. It may be more realistic in a acute leukemia, lymphoma type circumstance where management is fairly acute. I certainly deal with those acute chemistry and coagulation, and I've sent ambulances to people's houses in the past as well. It may quite frequently happen that the patient's going to see their report before the ordering physician does, and if they get in touch with you, the recommendation that we're providing for the FAQ that APL will provide is, you're always safe discussing what's in the report and what you're able to discuss. I mean, if the questions veer into management and next steps and things, you can always refer them back to their ordering physician to manage that. But if they have questions about the stage or the grade or things like that, and that's something you can discuss because it's pertinent to the report or the criteria in the report, that's certainly something you could do. Now I'll pass it back to the CMPA.
Thanks. So first of all, Kelly, pathologist contact information is being stripped from all new reports being sent to MPR. So your contact information won't generally be there. Now, there are some cases where patients may be accessing retroactive reports or retrospective where they might get in touch with you. But that was one piece of feedback that we got from the section early on. And so that information will not be available to patients. There might be the odd one it sneaks through for some weird technical reason, but in general, your direct line will not be available on the reports within MPR. Steve, do you want to comment on the AHS portal on that? And then I'll talk about my discussions with the CPSA and the CMPA about this issue.
And my understanding is that that contact information has never been visible within the pathology results that are shared through the MyHealth Connect portal. So that shouldn't be an issue. I know that they show up in some other reporting, but they're not visible in the portal itself.
And then with respect to the CPSA and CMPA, so we discussed this results reporting with the CMPA, and they essentially had few concerns about it because in their experience, it actually reduces complaints, legal complaints against physicians, because patients are empowered to catch things that may have fallen through the cracks previously. And so certainly talking with the CPSA and this information was developed with the CPSA. They just didn't have anybody available tonight to join us. But with the CPSA, as long as you stay within your scope of practice and you aren't making recommendations that are outside of your scope of practice, you are completely fine. So as Dave said, if you're talking about the results and what's in the report, you should be on very solid ground. Does that answer your question, Kelly?
Sorry, yeah, it does. I guess that's actually answered my question very well. This might be a little bit off topic for this venue, but I really have nowhere else that I've been able to ask this question. With respect to billing, and I haven't billed since I practiced as a family physician 16 years ago. With respect to billing, I presume that our ASLP, like our division within AMA, is going to offer some counseling on that or guidance in terms of how we proceed with billing.
Yeah, I'll comment on that. So if you have a PRAC ID, you are always eligible to bill within the province of Alberta. We've had a few sessions in the past where we've had the ASLP has put on a open house, and we've had CPSA come and have that discussion. But there is no restriction on it. If you're doing something outside your medical services agreement, and I suspect patient consultation would be outside of your medical services agreement. If it's within, if it's stipulated in your contract, then your salary is covering this, and you wouldn't be able to bill for it. So those are the considerations, and we can talk about it offline, Kel.
Yeah, no, I'd definitely like to, because obviously when I signed up with CLS years ago, I moved out of family medicine for a variety of reasons. And although I love speaking with patients, I'm really struggling with all of this. I think you could probably hear it in my voice.
You're not the only one. We're happy to do more sessions.
I think this is a big change for everybody, Kelly. Very few of us are used to this across, all facets of medicine. And so, there's really valuable questions that people are asking about this. And once this happens and goes live, I would just like to remind everybody that the AMA is your association. And if this is creating substantial distress or problems for you, please let us know. And, as always, there is the Physician and Family Support Program, but on a more sort of less mental health and more, this is really not working well in my practice, please let us know. And you can do that a variety of ways, either contacting the president, contacting your section executive. I'm happy to hear about it as well, any of those things. So I would urge you to give it a try, see how it goes. It's, from talking with people in other jurisdictions, it's usually not as bad as people fear, but that's not to say it's going to go smoothly in all cases. So let us know if it's creating big problems for you. Okay. We just had a couple of other questions at this point, and one of them was maybe for you, Dave. Would AHS support a clinic for patients to meet with lab physicians? And I think, Dave, you've had some preliminary conversations about this.
Yeah, we've seen a few models. Todd's right. One of which we actually had a speaker come in from Massachusetts to talk about what their department had done to support patient consultation. And it's nice in certain ways because it kind of self-selects the pathologists and laboratorians who are more willing or comfortable really to talk to patients. And so it has been an option. I've raised this with APL executive, and they will consider it as a potential option. The counterpoint to this is the idea that often pathologists feel that the best person to discuss the results would be the person who died or who wrote the report, so that they have sort of more control or ability to explain what they were thinking or what they did in their diagnosis. And so, you know, we have to balance those two particular interests as well. But if over the course of time we see the volume is high enough and patients are getting in touch more than we thought, there might be a reasonable grounds to develop something like that.
Thanks, Dave. And there's one more that I'm going to change slightly. And so I will have this probably be the last question, other than there's been a couple of comments pointing out the importance of change management. So having to address changes with support staff as to how to manage these issues. I think that crosses specialties, and also needing some change management in using tools for documentation, perhaps. And so those can be taken away by the sections exec and you know, for feedback. The last question that I will put to everybody is, there is a question here about patient resources. And the question is particular to mypathologyreport.ca, which I know the section of pathology reviewed, Dave. So if you want to comment on that, but also patient resources in general. Are there good resources for pathology, other aspects of lab medicine, or genetics, or any other specialties for that matter, that patients can be referred to? As we know, there is information in MyHealth Alberta, but when it comes to genetics and pathology, it's rather basic and probably doesn't deal with the issues. So Dave, I'll give you a first shot at that one.
Sure, thanks, Heidi. So we actually have met with Dr. Wasserman. We did a review, the executive of ASLP did a review of the website and the documentation. And you know, it is quite an excellent resource. The concerns from the pathologists that did the review were a few things. One was, you know, and this is more of a, I feel like an academic concern or a physician concern, is that, you know, it wasn't cited. A lot of the resources weren't cited, but Dr. Wasserman fully admitted, you know, he's trying to write this at a certain level for patients to be able to comprehend and understand, and getting too complex and then citing primary literature and things like that, it doesn't add value for the purposes of the website. The other thing he did mention, and I think ultimately the reason why ASLP didn't officially endorse the site was, I mean, he is struggling to, he can't do every type of cancer, whether it's gynecologic or breast or GI or something. And it's a one-man show. He's struggling to keep up. And that also, you know, is a limiting factor. We could stand it up more if, you know, say Alberta pathologists and the Ontario pathologists who have patients using those resources were willing to also help develop or you know, crowdsource the information, frankly. But it wasn't at a place right now that we would fully endorse it, but that doesn't mean it's not a good resource for patients. We just can't find one that would be written at a patient level for comprehension and is resourced particularly well. And that's unfortunate.
Okay, genetics perspective, Oksana or Julie?
Yeah, thanks, Heidi. So first of all, just to come back to the discussion, I find it a very interesting discussion with the point of view from pathology, because in genetics, our feeling is that if a patient that's not a patient of ours and has a genetic test and then calls us, that we actually would not talk to them on the phone and would ask their physician to refer them to us. We, of course, if any physician who's done genetic testing, and many of the specialists now do order their own genetic testing, we would, of course, help them to interpret the results, but we would not be talking to patients directly. So it's interesting to hear from pathology that they feel differently. With respect to genetic resources, there is a site called Gecko. I believe it's out of Ottawa, which has very good explanations. We're also developing some videos about that would be available through probably through AHS on exome sequencing, what it means, what genetic testing means. So both Calgary and Edmonton are collaborating on developing some video information that patients can look at. I don't know if Julie has other suggestions.
Yeah, I would add to that even though as a clinic, we would like to have patients been referred that aren't our patients to the clinic, but definitely we're happy to speak to anybody of our own patients. There are some genetic counselors in the APL laboratories that work specifically with genetic testing. So, and that's where you're going to find their contact as well as that on that website that was shared. So I do know they get a lot of calls both from physicians and patients, and they're integrated with us as a clinic. So they might be a good research resource for that. But I think we're going to have to see how this plays itself out. I think we're struggling with resources to address all the issues and genetic testing exploding. So I think we're going to have to do better. And in terms of resources, I've also had some preliminary chats with our lab colleagues, but how can we make some of the reports a little bit more friendly, so a little bit more amenable for patient to understand. So there is no equivalent website that I'm aware of, such as my pathology that was mentioned before. So I think that's something that we could maybe think of building, but at least at first, if we could have a patient interpretation on our lab reports. So I think that's going to be one of the projects as this rolls out that we're going to try and build with our lab colleagues. To understand, but we also can't strip anything, just like the pathologist, from our standards of reporting that we have to keep in there. What is the classification of a variant, and all those other things have to stay there. So it's finding that right balance that I think we're all struggling from, and probably echoed a lot from my pathology colleagues.
Fantastic, thank you. So lots of learning to be had in the future about how we interact in a system where patients have much more information than we've traditionally been used to them having. So I want to thank all of the presenters tonight and my co-host, Dr. Steve Turner. We are finished with our time. There is a QR code and a link on the screen. If you could please fill an evaluation form, we would really appreciate that. There's also a link in the chat to the evaluation. And the continuing medical education certificates will be available in the AMA membership portal after a couple of weeks, and you can go in and print them on a self-serve basis. Thank you so much, and stay safe and have a wonderful rest of your summer. Thank you.